What's up, guys? Welcome to the PT Good podcast, where we talk all things ortho, from physical therapy to training. My name's Kane.
And my name's Mark.
All right, Mark. So what is on the agenda for today?
All right, Kane. What we got today is a continuation of our previous episode about total joints. We did a bit of an overview in the previous episode of, just common things we see, total joints, how we approach them. We talked about prehab, things like that. In today's episode, we want to talk about, things we emphasize in rehab, common deficits we see, common issues we run into, are solutions that we found that seem to work when, we do run into these things. And we just want to talk about, maybe slightly different approaches or, like I said, issues we run into, things that people may see in the clinic, and how we would address it.
Awesome. So the first topic you said is things that we emphasize. So I think we touched base on it last time, but let's just do a brief recap on like the things that you typically would emphasize for a total hip or a total knee.
Yeah, I mean, I said I'm big into, especially the first couple weeks, like motion mobility seems to be the biggest thing. Like, I mean, strength, like some muscle activation, things like that. But I just feel like if you can get the range back sooner, it's just easier going forward, and it just makes the strengthening exercises more effective. You're working within a greater range, and it just improves function down the line, and it just makes your job easier going forward. So, I mean, first couple weeks, range. Once we get enough range where I feel like, the strengthening type exercise is going to be effective, or at least, worth working in, you start doing that, and the functional stuff gets worked in appropriately depending on, how the person's feeling. And you said, like, you recapping from last time, you work in more functional stuff a little bit sooner.
Yeah, I do. I think I will load people up on a TRX squat pretty quickly. If they can tolerate it, I will get them on it like day one pretty much.
Yeah.
I found really, really good success with it, and it just kind of teaches patients like that it's okay to move and to push into like some of that discomfort to help mobilize their knee, and to kind of teach them to sit into their squat a little bit more, which I do want to talk to you about the conversation that I had with my mentor yesterday, where we had a bit of a discrepancy in how we utilize the TRX squat, and or at least like how we kind of approach it. So he said that he actually starts off with sit to stands, and I was like, oh, that's really interesting, because like I progress people to a sit to stand, and in my head, and younger me always thought sit to stands were like the regression. You have a chair, you're sitting back, like you it gives you a place to rest. But I think for me, what I've noticed is when you do a sit to stand, you're taking away all their momentum, and you can actually be a little bit more nitpicky. I've noticed that a lot of my patients struggle a whole lot more if I have them do sit to stands first. Like, they really, really struggle. And even then, by the time that they're getting close to their discharge, some patients still, like, they will be able to squat, no problem. They can do it. With the TRX, they can do it at the counter. They can do it like normally, but they still struggle to do a sit to stand without momentum, or like, or cheating in a way, or using their arms to compensate. But one of the things that we did was we actually flipped our order, where he does sit to stands first, then moves to squats, and he may use like the assisted stuff like in between there. Versus for me, it's the exact opposite. I'll use a bunch of assistance beforehand and then gradually work my way down. So it'll be like, sometimes people are just more comfortable with a counter squat, but I find that knees tend to like the position of a TRX a lot more. So when they're able to do that, they can, like I said, sink deeper, and it offloads the knee because you're using your upper extremities to help take away some of their body weight. You're not helping it like during the squat per se, but you're just helping to offload, similar to like what we talked about, how you use the Vigor gym, you know? But yeah, I found that to be a very interesting discussion, that you can approach a problem from two different ways and still have similar results, you know?
Yeah,
What
definitely.
do you fall anywhere on that spectrum, like between one versus the other?
Well, I definitely like. I don't use the upper extremity assisted, like the top down squat too much. I guess I do typically start the sit to stand, right? So I would just use like a high low table just to height and start from there. Yeah, I mean, where I work, we don't have a TRX, but I mean, we could, do like a upper extremity assisted squat differently, definitely. But I guess just because I've used the high low just to start as a sit to stand, to start like elevated. I guess I have felt like I haven't needed to do that. Like one thing I'll do, I'll start, even have I'll have the table pretty high, and I'm not too worried about I'll have them do the top and or the concentric and the eccentric movements differently. So the concentric is just like, want them to do it quick. I'm seeing if they're loading equally, or, we expect that they're going to avoid the surgical limb to some degree, which is, okay, fine in the beginning. The lowering is what I'm more concerned about. So I might even have them like, maybe the concentric's really easy, and then I'll just have them slowly come down like that, even if it's just like a tap to the table, come back up, and then we can gradually decrease the height from there. But that's typically how I address it. But not that I'm against, or I just haven't even really done the upper extremity assisted like lowering. I just haven't gotten into it, so maybe it's something I can try. But typically I do the opposite.
Yeah, I think that's like a really, really good introduction, is if you hammer them with sit to stands on a high low, it gives them an objective to continue to reach for. You can really get a high low table to help assist them, but also you can really drop that thing down to make sure that they're being challenged, and it's like you can challenge them enough while controlling their range, so that way they don't compensate like too badly. I think that's a really good way to prevent those like different patterns that you'll probably see.
Yeah, and like adjusting, you can even do like within a set of that exercise, you can adjust the height. You can make it higher, you can make it lower. Not that there's a little bit of, if you're really looking to develop that control, like you said you can change the height within the set, so the patient doesn't know, exactly where it's going to be at, right? Also, if they do know the height, you can, I find when we're talking about like getting the range of motion back, like whether it's, you're doing a knee extension or a heel slide, or if it's like a closed chain thing, a sit to stand, if you give them a target to work towards, I find it can, that external cue is something that can help the patient be able to reach for, right? So if it's like, okay, you're going to sit down to the table, it's going to be at this height, right? They kind of understand what they're going for, the range they're supposed to use. Similarly, if they're trying to get, let's just say like quad strength back, and they're doing a knee extension, they don't have that last, 10 degrees of extension back. You can just, you have your hand up there as a goal for their toes to hit, and then all of a sudden, they're able to just kind of reach and get there, right? Compared to if there's nothing there, they're just kind of squeezing. But that's something I'll utilize. Is that you ever utilize any kind of cueing or little like tricks like that just to get some range back? Maybe like even like a heel slide, you'll have put like a dumbbell on the table, like exactly like at, you can measure like 120 flexion or certain degrees. Okay, I want you to touch this each time you get there.
So I haven't done that specific example, but I will, if I have a patient on the bike, for example, and they haven't been able to, like they're just a little bit stiffer that day. They've seen that they can already do full revolutions. I don't usually have my patients just rock too much, to be honest with you, unless like, it's been a while and they really need that motion. but maybe they come in and they're like, oh, I'm really stiff one day, and what they'll do is they may rock for a little bit, and then after that they're like, oh, I can complete like full revolutions now, and
Right.
now it's starting to ease up, and then after that I'll actually bump them forwards, and then I give them another goal to kind of shoot for.
Sure.
So
Yeah.
I find that having them see that progression kind of drives that a little bit further, because they're like, oh, I'm going to gradually get better. I just need to give it some time and slowly warm it up, and then after that it'll loosen up, and then we can go again. Same thing goes for like the leg press too, actually. So we talked about how I like to load things functionally to help with their range of motion. So for the leg press, there is a seat number for us, and I'll actually track the seat number that I bend them to. Right. So the lower the number, the more that I'm bending them to. And so I'll track that each and every single time. And that way I can make sure that, oh, not only am I progressing them on how much flexion I'm putting them into, but now I can increase that weight. And obviously you're increasing the weight under a greater range of motion. That's going to make it a little bit tougher for them. So, keeping track of it that way and showing them their progress that way, I find to be like really helpful for them. It's not a direct target per se. Sometimes they're just like hovering in the air where they just can't quite touch. And I'm like, okay, try to touch every single time, and just like you said, it gives them that marker to kind of like shoot for.
Yeah, something to work towards. Yeah.
What about you? Like how often are you typically incorporating stuff like that into your treatments?
Not too often, I guess. I mean, I find that most people are able to they can usually get there on their own. If I'm noticing just like each session, okay, they're a little bit, 2, 3, 4, whatever, 5 degrees better. Each time they come in, gradual improvement, functionally they're improving. I don't see a reason to have to push any farther than that, right? So we talked a little bit last time about, really like cranking into, passive range of motion, really working into it. If I'm noticing like a steady improvement, and by steady, I mean it can be really gradual, right? A couple degrees of range of motion each session. I don't find the need to have to like do anything extra to push it forward as long as that trend's continuing, right? So yeah, that kind of stuff, I don't do it too often. I said if someone's really struggling, or if they just, let's say they're at like, they've been lacking 5 degrees of extension for like, 1-2 weeks. And I'm like, all right, let's just try something different just to really see if we can get that couple degrees back. I'll throw it in. But otherwise, I'm just looking for a good steady improvement.
So how much are you emphasizing getting their range of motion back? Like how much are you expecting to get back? Or do you get to a point where like, I'm kind of plateaued here. I don't think we can get much more.
Yeah. So this is an interesting one just because we talked last time about preoperative evaluations and, what we measure there. And people come in and let's say, they got their knee, they've had a 15-degree flexion contracture for like, 5 years. They, haven't been able to straighten it. They can bend to like 100, right? Most of these people's expectation is that they're going to get the surgery and they're going to be able to have a fully functioning knee with like, the exact same range of motion as the other side, which in my opinion isn't the case. Usually I tell people, hey, listen, like, it's painful now. The idea is that the pain should go away. I think you'll get some range of motion back, but for you to be able to straighten this knee all the way, it's going to be pretty difficult, right? So maybe there's changes within the joint now that are leading to that have led to the decreased range of motion they have. Their expectation is the joint's going to be replaced. Whatever is in there causing the decreased range of motion isn't going to be there anymore, so they're going to be able to get it back. But there doesn't seem to be any talk from the surgeon standpoint about any other structures that have adapted to restrict range of motion, right? So, I mean, you're going to have just soft tissue restriction all over, right? If your joint has been in a certain position for a certain amount of time, including the soft tissue, like joint capsule, right? You're just going to have like, even if you start to get that range of motion back, you're going to have a protective response from the surrounding musculature. So I have definitely have a conversation about people expectation wise, like, hey, there's your knee's been like this for a while. I think you'll get some range of motion back. I don't know if you'll, especially like I said, let's use the example of a 15-degree flexion contracture. I don't know if that person's ever getting to neutral. We'll definitely try, but I in a case like that, I maybe I expect them to get. Yeah, I guess that's how I put it. I think you'll get some range of motion back. I don't know if you'll be able to straighten your knee all the way. It should be better than before surgery. Compared to somebody who comes for pre-op evaluation and they have full range of motion, maybe it's just something, hey, it just really hurts if I walk for more than a couple minutes, so I'm getting this done. The range is good, their strength's good. That person, I'm expecting them to be able to get that same amount of range of motion back, right? Maybe I'll tell them, hey, I don't know how long it's going to take. You should get there. Your joint is functioning well now. It's just, it's painful and limiting, so you're getting the surgery. I think you'll get this amount of range of motion back. So those two different scenarios I frame it differently. Have you had any patients come in with, long history, restricted range of motion? And if you have, do you prepare them in any certain way, or do you have any certain expectations for them going forward after the surgery?
Oh yeah, pretty much a similar thing that you said. If they have had that flexion contracture, if they've been walking on a flex knee for a while, that's their gait for however long they've been doing that for. It could be if it's a few months, I'm less likely to think it's a big issue. If it's a few years, if they had surgery that left that didn't go so well and left their range of motion the way that it is, I am much less likely to think that we're going to get it all the way back. Are we going to make improvements? Sure. But I usually tell my patients, like, hey, the range of motion that you have in your knee currently, that is our baseline that we want to be able to get it to. And if there are improvements from there, that's awesome. I will be sure to get as much of it back that we can.
Yeah.
But if it doesn't go any further than that, that's kind of like the expectation. That's like what we want to be able to achieve, and I think that kind of realistically sets up their expectations, and they'll usually exceed that. So they're pleasantly surprised. But it's just something that, hey, just in case, you never know when a surgery is not going to go the way that you expected it to. So what are the benchmarks that you typically go for when it comes to range of motion?
Yeah, I don't know if I have. Well, if I'm going to put numbers out there, 5 degrees or less of extension, and then I don't know, say like 110 flexion. I use the flexion number. Basically, I'm using it for, can you get up from a chair? If you're on the ground, can you bend your knee enough to essentially do a lunge to get up? That seems to be good to go for. Sometimes, and this is something I see with the knee replacements, is people like, oh, I can't, if it's hip flexion and external rotation, but they're trying to bring their foot up like that, but they feel limited in their knee, right? So sometimes, not that, you're using full knee flexion there, but that you have that kind of rotational component. Sometimes that's like a common thing people look for. So maybe if they're specifically saying like, I want to put my shoes or socks on, I need to bend like that, sometimes I'll use that specific motion as a benchmark in addition to the isolated like knee flexion measurements or movements that require that amount of knee flexion. For hip, I use that same thing, putting shoes or socks on, right? That amount of flexion, external rotation. People are usually happy with that. There doesn't seem to be, function-wise, usually hips come along fine in terms of like getting functional range of motion. So yeah, I'll use that kind of movement, that hip flexion, external rotation, use that for knees and hips, and then and then for regarding extension for knees, just so being able to walk normally. Yeah, that's usually something I look at.
Yeah, I feel like for hips at least, extension is usually what's lacking. Flexion is not the main issue, but people really notice when their extension's lacking, even if it's by a little bit, because it affects every single step that you take, every move that you make. So, yeah, I think that that's just like one of those things that you're definitely going to feel. For knees, I feel like people notice flexion quite a bit more compared to extension. Because, like, if you're close for extension, it's not the end of the world. You know, they just don't notice it quite as much. But if they can't bend it, man, they will let you know. They will tell you every single time. Like, they can't squat, they can't garden, they can't like kneel, they can't sit. It's hard to get up and down from a chair because of it. It's all these things come out the woodwork when they can't bend. But I do agree with the numbers that you use. I for the most part definitely agree with the extension one. For flexion, I have, like, if someone is really good, my expectation is to get them to like 120 to 130, whatever I can get them back to, you know?
Yeah.
Functional for me is 115.
Okay.
And like, if you're on the bottom end of that, I want to at least get you to 110. If you're at 110, you'll be able to compensate and make it functional, at least, you know?
Right.
But 115, you should be able to clear most things without too much of an issue. Like, you'll be okay, but you probably won't be returning to high level stuff very quickly. It may need some time, or it may not come back at all. But it's just one of those things where it's like, I try to tell patients that it's just like, sometimes you just need to let things settle down more and things will be okay. But it's really, really tough to get that last bit back. And a lot of it is going to be dependent on the patient, on how much time and effort they're willing to commit into getting that range back when they're done with PT. I think that's like a huge thing, is they actually have to continue working on it once they're done.
Yeah. Do you have you had any patients, maybe you do, 3-4 months post-op, and then they come back like a year or two later for something different, or maybe the same thing? And have you seen, let's say they come for something different, you're just looking at their knees, seeing how they're walking. Have you seen that maybe they walked out, the 3-4 months after post-op, and they were lacking in a certain range of motion, and they come back, like, let's say 2 years later for something different, and you're just kind of looking at their knee, and their range ends up being fine? I know, like, there's something to get talked about in school and stuff, where it's like, the tissue changes and collagen, 6 to 8 weeks, hard to get back afterwards. But at least from what I've seen, and this isn't, everyone, sometimes, these people walk out and they're lacking 10 degrees of extension. They come back 2 years later and the knee looks fine. Just like, okay, maybe they used it. Maybe it just took more time. Maybe it settled. You know what I mean? Have you had that experience at all?
Oh, for sure. I've had a few patients where I tell them this, and then, like, I run into them because, like, our clinic is right next to a gym that a lot of patients will go to. And so I'll run into a bunch of, like, my previous patients, and I'll see them. I'll ask how their knee or hip or whatever is doing. And they're like, oh yeah, remember we had this issue? It's not an issue anymore. Or I completely forgot that it was a problem.
Yeah.
It just needs time, for a lot of things. It's not like, I do not expect to get them 100% of the way there. Even for like the top cases where I'm like, wow, you're doing phenomenally. You're going to be discharged in like a handful of weeks and you're going to be good. Those people, I would say their function still really continues to improve. Like, I'd say that we probably get them to like 85 to 90% of the way there. For a lot of the cases, but that extra like 10, 15, 20% difference, as they continue to let the joint, what I usually say is settle in, their new parts settle into their joint and mature. And that's a term that I realized was really helpful, and that I picked up from the surgeon when I was rounding with him, which is like, your joint needs to mature alongside with you. It needs to learn how to how it works now, and your brain needs to form those new neural connections, or lack thereof, and to fill in those gaps. And when you have all that information, it just helps things be able to move a little bit better. Now you have more information, at least your body does in regards to that. So I do find that time is a very, very helpful factor for a lot of my patients.
Yeah, I like that. It kind of, you said, needs to mature, settle in. I mean, like I think at least where I work, the surgeon gives patients a timeline. Like, hey, this is probably going to take a year before it gets 100%. And typically, what I tell people is, you may get that first 90% back within the first 3, 4, 5, 6 months, and then the rest is going to come. Which, yeah, maybe that last like 10% is that little bit of range of motion, a little bit of strength that you need to get there, and it just has to do with what's going on inside the joint. Yeah.
All right. So, one thing I wanted to ask you about was, do you ever like take into consideration end feels, like for a joint when you are ranging them?
Yeah. So one thing early on is, especially with knees, we know there's going to be intra-articular swelling. We know it's going to be painful, right? So I find, and especially if they have, well, I guess regardless if they have staples or if it's glue or whatever, the flexion is going to pull on that incision. The amount of intra-articular swelling we have is going to expand the joint, or require some at least, and that swelling is going to limit that. So I don't tend to push, especially if a patient, they have higher irritability because of the swelling. I don't see a need to really push flexion a ton early on, right? I want them to move. I want them to be able to work that swelling out. But especially like you talk about end feel, like if I'm doing flexion and I'm just getting like that, what's the term? Boggy, like that, like just like,
Boggy.
yeah, boggy. It's just like, I can just, you could just, you're not running into anything. It's just kind of like almost like soft. It's just like swelling. You can just like, squishy. It's just like not moving anymore. I don't know that I need to really push the flexion a ton earlier on, right? Similarly, if we're flexing and we can get some tension on the incision and stuff early on just for the soft tissue adaptations, but especially if we're like a week or so out and it's not fully closed, not that I'm afraid it's gonna like bust open or anything like that, but I'm a little less likely, or I'm more likely to take into account that kind of end feel, and then will be less likely to really force the flexion early on. Yeah, so I definitely take into account the end feel in that regard. Extension, yeah, sometimes like maybe the swelling limits. I don't know if the response is similar to flexion, and then for hips, yeah, I'll take it into account, but I don't find that I run into any like different kind of end feels with hips, or just kind of like get there gradually, work into it, right? But yeah, what do you think of that?
Yeah, I definitely use end feels a lot as an indicator for like how much more potential range of motion we have, right? Like if they're pain limited and it's completely empty, to me that's like, okay, so we still have plenty of room to go. Like we can still keep going, or even better, if it's not painful per se, if they're like, oh, that's really tight, I can't keep going, but I feel that they can keep going. That to me, I'm like, okay, that's good. Like I know I have room to work with here. But if I'm getting to like a harder and firmer end feel, then I'm usually like, oh, like that's going to be tough. I don't expect I mean, part of me, I get those, what do you call it? Those thoughts that come into your head where I'm like, bro, I just want to manip this and just like make it go further. Like you've been stuck at 90 degrees for the past like 2 months. Good God, just let me slam this thing home.
Come on, can't resist, right? It's like the same when it's like they're on the bike and they're so close to going around. Like it's like that intrusive thought. Like I'm doing it.
Yes.
Listen, I always got consent. I tell them it might hurt a little bit, but then when they go around, like, yes, it happened. I'll go home happy today.
Jeez. But yeah, so I definitely use end feels a lot to tell me how much more I'm probably going to get out of it and what it's going to feel like. And also just like as an indicator for what the patient's probably feeling too. I find it to be very, very helpful. The other thing that I'll kind of take a look at is like, sometimes I'll look at tibial IR and ER if that's like if their extension is really problematic. But I find that those tend to just get locked up after a total knee.
Yeah.
Like that is really not moving. And like sometimes it'll help in regards to their extension, but I don't put like a whole lot of stock into it. It's just like if it helps, it helps. If it doesn't, like I'm pretty okay with that. I think it's a relatively low success rate, but it's something to kind of keep in your back pocket. What about for like, do you ever do patellar mobs, by the way?
Not really. Like, kind of, maybe, somewhat. Sometimes, if like maybe the first week or two. But even saying that, I can't tell you the last post-op patient I did it on. I just think like I think there's a little bit, maybe some more important things to work on rather than that. Maybe if it's like the first visit, I'm like, hey, you can do this on your own. I'll put it this way: if they're like extremely painful and limited and they can't really do much, I'll have them just to not even from a. I'll have them do it on their own for joint mobility, but from a almost like a P&E standpoint, I'll have them. I just want them touching the joint. I want them getting some input to the joint. I want them interacting with it, right? So they can, their body and their brain can start to make that connection, right? So right now that the connection's it's blurred, it's a little bit fuzzy, right? They just had this essentially a trauma to this body part, and their brain's like, I don't want anything to do with it, right? So if I can have them start to do something, like this is for people who are extremely hesitant to move it. I know they're not going to do much. Hey, what if you just, move the kneecap around, just kind of, like I said, just some kind of interaction, some kind of input to the joint. Yeah, I'll work it in that regard. But if it's someone who is able to move their knee, they're doing their exercises, they're otherwise doing fine, I don't tend to work it in. Do you find it has any specific indications for, for use for patellar mobs?
No, not really.
Yeah,
not gonna lie.
yeah.
I think it's so funny because like the surgeon I rounded with asked me, he's like, dude, what is up with you with PTs and patellas? Like, why are you guys trying to move it? It already moves. What's the deal here? And I just looked at it, I was like, I am not the right guy to ask for that. Yeah. I don't really do it. It's like, if it's going to move, it's going to move, Yeah. I'd rather move it doing other stuff. I'm like, I'm not just pushing on your kneecap just to push on it, It just doesn't make sense to me. All right. So, Mark, we have a list of a few commonly run into issues. Oh, yeah. So we'll talk about these the common issues, and then we'll see like what are some things that you usually do to address it, or like what your expectations are, and things along that line. So the first one is like we kind of chatted a little bit about this, but I don't know if we covered exactly how we would address it, but like what is your approach to someone who comes in walking on that flex knee? They've been stuck in that flexion contracture. We talked about their expectations, but what do you do when you run into that issue? And sometimes, maybe they haven't come in with that flex knee, but maybe they just can't get that flexion back.
Right. Yeah, so I've had a couple cases of this where, and this can tie into the previous episode, I think this may be a case where pre-op has a place, right? So if they're up for it, I'll have them come in and, we can spend the entire session just kind of working into trying to reduce that flexion contracture. If we're able to get some range back, good. We expect to get some back after as well. So maybe that combination of pre-op and then post-op can get them to a functional range. Otherwise, I don't have a good answer besides like just setting their expectations. I find typically as long as the surgery goes well, like they'll be better than they were before. At least they won't be as painful. So that's a positive in my book, and certainly from the patient's standpoint, it's positive. But besides that, I don't really have any other. I don't have any kind of special trick, especially if it's like you said, like a chronic thing and it's just kind of been there. I don't know how much realistically we can expect to get out of it. Like I certainly haven't seen the case where it's like, they have a flexion contracture 15, 20 degrees and then they get surgery and all of a sudden it's just, better. I don't see that unless there was some kind of, mechanical block in the knee, but even then, like we talked about, like you're going to have other kind of things restricting range of motion. But yeah, I don't, besides expectations, besides maybe the possibility of prehab, I don't have any other different way I address it. How about you?
So if they are stuck in flexion,
Hmm.
I really don't like to crank on knees for the
Yeah.
love of God. But sometimes, like when they're in this position, you kind of have to. And it's not like I hold it for too long. Patients do not like a higher level or higher intensity stretch, I guess we'll
Yeah,
call it.
yeah.
For sustained periods, I'll usually just oscillate and they'll tend to respond to that a little bit better. The other thing that I'll do is I will address like soft tissue for sure. I actually have a patient and I've stepped away from soft tissue on total knees because they tend to just be a little bit more sensitive, even though if I feel like they could use it, but they just tend to be a little bit more sensitive in general and don't tolerate it quite as well. But this one patient that I had, she was really, really struggling with getting knee extension. And she was walking with like minus 15 like before the surgery,
Yeah,
and minus 15, minus 20, somewhere around there. She's at like virtually like -3 right now. She's
Okay.
really
Yeah.
close and she's pretty much getting ready for discharge. But to get her on the way there, I would pretty much mob her knee into extension, just like a
Mhm.
physiological mob. And then after that, I would load her to go into more knee extension, like terminal knee extension. So TKEs. I would do leg extensions with just the focus on getting that knee straighter. I would do leg press with just the focus
Gotcha,
on
yeah.
the lockout and stuff like that. But it didn't really close out. It was getting better and better and better. And then just a couple weeks ago, I did soft tissue work on her adductor, and she's like, "Oh my god, it's gone. Like I can
Yeah.
stand." So I think that your patients are going to give you some cues because she told me, she's like, something feels like tight and I can't like figure out like where. And then
Yeah.
the one time she's like, it doesn't feel like it's in my joint. And I'm like, oh,
Yeah,
all right,
yeah.
let's hammer this. And we'll see. And that's definitely something that I feel like you can take a look at to help in regards to that.
Yeah.
What about
I definitely look. Well, I guess I think this kind of comes along, and I don't know what came first, but just working any of that kind of soft tissue posteriorly, have people come in and maybe you're doing some nerve work too, a little bit of like sciatic, some glide, just working into that. I mean, we expect that posterior tissue if it's on been on slack for a while it's because the knee's been flexed and we go to extend it, there's a chance that's going to limit it too. So yeah, I agree there. Working in some of that kind of stuff.
Yeah, and there's another thing. Sometimes I'll use like the backpack trick. Have you heard of that, or have you done
Loop
that?
it up. Yeah, I have. I definitely like it better than just putting something on top of it. I like
I
below and
agree.
above the joint. I think that consistent pressure downward is more helpful than, like I said, just putting something right on top of your knee.
Yeah, for sure, for sure. All right, so we talked about the trying to get flex or extension back, but what do you do for flexion? What do you do to try to improve on that? Is there a change, or do you follow like a relatively similar recipe?
Yeah, it's similar. I do I don't do really at this point. Well, I shouldn't say I don't do any, but like 80% of the time, my knee flexion passive range of motion is off the edge of the table, just because I
Okay.
find that with gravity giving you some distraction and you can add some on your own, it gives you a little bit more room in the joint, a little bit more space to move. And I think
Yeah.
just especially early on, having the patient have a good tolerance to that position, they can start to do active range of motion on their own off the edge, right? Some people, like, let's say like they're at like 40, 50 flexion and they're just going to be tight and hold it there. If you just let them relax there and on the edge of the table, and I sometimes won't even push. I'll just be like, here, start there. just let your leg relax, and then all of a sudden they're flexing to like 80 or 90. Then we give a little bit of overpressure, right? If they can get to that position, then hey, look, now they're baseline. They're out in the waiting room sitting. They're going to be at 90, right? And at home, hey, sit off the edge of your bed, off an elevated surface. Now they can start to kick their knee. They can start to bend a little bit more. They can get some overpressure with the other leg, right? They could do like use a strap looped behind the chair or something and pull even more, right? So, I mean, not that you're not going to get that carryover if you do supine. I just find for me it's a better position. Like I said, I have gravity with me. I can, if I have my hand on the front of the ankle, I can provide some distraction, some like downward traction, and then add flexion in. It seems like it gives the joint some more room to move. So I like that position specifically for getting flexion back compared to we can say, standard supine. The other thing I do when if they're lacking the range of motion towards like past, let's say 100 degrees of flexion, is I'll have them supine. I'll get them into, let's say 80% of max flexion. I'll do a bunch of, let's just say like tibial posterior glides, and I have them keep their shoe on the table so that there is increased, so it basically gets stuck on the table, right? So they can't straighten it. I'll go to maybe like 90% of flexion, a minute of mobs there, and then I'll go to 100, and then just see how far it can go just while mobbing, and then having them do essentially like a prolonged flexion. But I'll save that's more like a mid towards the end. Maybe it's someone who's doing everything good, they're just lacking flexion. It's a longer duration stretch, but it's in certain increments, right? So I said I start submaximally, kind of just gradually work into it and giving the joint some input with the mobilizations, and then they're also getting the benefit of the prolonged stretch.
Interesting. I'm always still surprised whenever you jump to manuals, by the way, because that is still not something that I like to think of myself as a manual heavy person, but I think the roles are changing here, Mark.
You're learning, man. Well, it's interesting because I don't here. I'll put it this way. I just think, like, especially if I'm like, all right, we're getting some range back. I just know the person's gonna. It's hard for the individual to push themselves to the point they need to get, especially if it's like a stubborn joint, especially if we're like later on in rehab. I'm just like I want to get in there. I want to move it, right? So that's what I do, and yeah, I really like. I mean, we've talked about this in previous episodes. I really like just making some room in the joint. Let's say some distraction. Sometimes even supine, like I'll do like I said, the posterior mob while they flex, or maybe the posterior mob while they do a heel slide, stuff like that. So yeah, just kind of work stuff in like that. What do you got? What do you got?
So I treat it very similarly to how I treat someone who's lacking extension. I will, like I said, I have them squat. I have them do the leg press so that they can sink down further, usually like single leg, sometimes double leg if they're like more sensitive.
Yeah.
I'll have them do like step downs and have them constantly try to settle down and reach a little bit further and further each time. So I'm really big on trying to get that knee flexion to increase like functionally and with load. Those are like my really big go-tos. The other one that I really like is the chair stretch, where you are sitting in a chair, you move your foot back to increase knee flexion as much as you can, and then you just hang out there. And then after that, you just scooch forward a little bit, I think that gives patients something to do when they're sitting and hanging out for longer periods of time. It is a strong stretch for sure. And it's something that they can consistently do multiple times over the course of a day. And I find that is pretty much like the backpack stretch, sure. Or like that you do for extension. But this way, like you need that time, like I can't change all of that. Like it's just like you need the sheer amount of volume to help change some of the tissue and get it to be a little bit more compliant, So those are like the main things I typically will do to address flexion deficits. I think after that, like for the most part, because I address it functionally and they're able to do those things in their normal day-to-day life, or they see how they kind of connect, they are much more willing to push that. And then they're a lot happier because they're hitting those certain milestones, you know?
Sure. Yeah, definitely.
All right, so I do want to jump back real quick, and this kind of relates to extension, but what is your take on doing repeated knee extension for total joints, like, or even hips if you want to include that? But do you do it to achieve a change in range of motion? Do you find it to be effective or anything like that?
Now you're talking like, we're addressing it from a like mechanical standpoint, like, maybe.
Yeah.
Yeah. So, I mean, I think if we get to a certain point and someone's having some kind of issue, whether it's like pain or an obstruction in range of motion or, whatever it may be, I think at least they deserve the assessment, right? I'm not saying that, it's going to cure all their issues, but I think just assessing it, like we talked about before with our like test, retest, repeated movements, yeah, why not throw it in? Just because they're post-op doesn't mean they can't have a presentation that would respond to repeated movements or have directional preference, right? So yeah, I definitely work in when it's appropriate. Now I'm not going to, tell them, let's say they're having similar pain to what they had before the surgery, and we do a repeated knee extension or whatever it is. We go through a mechanical exam, we find directional preference, and it helps their symptoms. I'm not going to immediately jump and say like, oh wow, you didn't need the surgery or anything like this. I'm just, it's just, hey, it's something we can work in, right? I do it if it helps, great, right? You know what I'm saying? Like I'm not going to, start to.
It's not like you force it, but it's like
you also, to the patient, it's just something that it's like another. To the patient, the surgery was necessary, right? The presentation has changed. Their structure has changed. So I'm not going to jump and be like, act like I'm some, sacred healer that can cure everything and no one needs surgery, right? But like I said, even like post-op, like when it's appropriate, I think you can work on the mechanical assessment, right? Especially if someone is coming in and they check the boxes, right? They have variable symptoms. Sometimes it's good, sometimes it's not. Range of motion loss. Yeah, like I said, if they're checking all the boxes, it makes sense. The presentation, we're not working it, especially for knee. Like it's just, okay, hey, straighten your knee a couple times. How's it feel? Here, bend it a couple times, right? It's pretty simple to work in. But yeah, I mean, I think it's good. If anything, like they're probably going to be doing that kind of movement anyway when, you're working in quad sets, stuff like that, right? So you might get some information there. But like I said, it's the joint is it's evolving. Like you said, it's maturing, it's settling in, right? So the presentation is continually changing. Not that you have to address it mechanically like every single session, but yeah, if someone's having like recurrent symptoms and it's like, why not check it out? Why not look at it, right? So it's not like you're like completely changing gears. It's not like they are having it's not like they're got a knee replacement and then now you're going to spine and saying their symptoms are coming from there. To the patient, it's just like, hey, we're doing another knee exercise, right? So it's not like you're completely switching gears or changing things to the point where the patient's going to be like, oh, think that they didn't need the surgery or something like that. But yeah, I definitely work it in. I mean, like I said, when it's I don't force the issue. I'm not like right when they get to the 6-week mark, I'm not like, all right, we're doing this kind of reevaluation, blah, and it's, I'm not seeking it out per se, but if I think it's there, yeah, why not test it?
Sure. I think like I've seen usually for hips, it'll work a little bit better, like a repeated hip extension to give them that extension moment back. But I don't treat it like a mechanical issue. It's more or less just like we just need to mobilize it, and same thing for the knee. I've seen repeated knee extensions definitely work, but it is more when they are further down the line, or even then, like maybe a few years post-op. I do not use it necessarily to treat like a post-op knee. That is not my goal with it. Sometimes it's just to increase mobility, but
Right.
I do not use it for those like rapid changes. Maybe when they're like returning, like fully returning and back to their normal day-to-day life, and they still have these residual issues with their knee, and it presents similarly to what I would expect to see as like a responder for a repeated knee extension, then I'll do it. But it doesn't, just because it's an artificial knee doesn't mean that it won't respond to stuff like that anymore. So it's definitely something to keep in your back pocket just in case.
Yeah,
Now,
like even when we talk about those presentations, like there's nothing that says it has to be, it's a clinical presentation that responds to certain movements, right? So there's nothing to talk about structure. So it could be, yeah, it can be anything, right? Even though maybe we're thinking it's something within the joint, like it doesn't matter if it's an artificial joint or whatever. You said if it's there, it's there.
sure. Now let's chat about like these next bits. They tend to be a little bit more, I guess, like less common of an issue, but they certainly can still be present. But the next three I would say would be numbness, swelling, and issues with their incision. Like when the incision becomes like fibrotic and stuff like that. What do you do when a patient comes in? They start talking to you about like, oh my god, like this area of my leg is numb. How do you educate them, or what exactly are you talking to them about? Because there's that numbness could be like normal, or it could be like, hey, like I don't feel a thing, like
Yeah.
when are you concerned, when are you not concerned?
Yeah, I mean, especially if it's like let's just take knee and excuse me. Like if they get that like anterior shin or like anterior knee type numbness, I don't really feel it or whatever. It's like, okay, that's kind of what we expect, right? The super, what they pretty deep incision they're getting into the joint. Maybe they're going to hit some of the superficial sensory nerves. That's fine. That's what we would expect. If they have sudden onset like numbness and it's in along with, let's just say, like motor weakness, right? I think it has to be a combination of things before I start to get like concerned, right? Maybe they have calf swelling, redness, and then they start to have like numbness in their foot, right? Okay, so if it's just like numbness on its own, if it's just tingling and it's in the I said anterior knee, anterior leg, shin type area, I'm just kind of yeah, okay, we expect that. If there are other things going on that would cause concern, then we have a different conversation, I guess. But not too, yeah, just a numbness on its own. To me, it's like, it's there. It might take some time to get back. Usually the surgeon has a similar message where it's like, yeah, there's a big incision there, right? You probably hit some nerves that there's not really any way to get around it. It might come back. It might not. Yeah, like I said, in the absence of any other symptoms, it seems like it's usually fine. But I don't tend to address it in any certain way. How about you?
Yeah, I find that like when we talk about the numbness, I usually tell them that it will return. It will start to come back.
Yeah.
Whether it comes back all the way or not is a different story. But usually you'll start to see some of your sensation start to come back, and you'll notice that it shrinks. And what I usually tell them is the nerves regenerate typically at 1 millimeter per day. Right. So,
Right.
I believe that's a stat, right? Per day? I'm pretty sure.
Per day? Wait, let me think. A
Um,
millimeter? Dude, I don't know.
I can't quite recall. I
Yeah, I
think
don't
it's 1
know.
millimeter per day.
I'm trying to think.
But
Wait. Let's hash this out real quick. I don't know if that's quick or I don't know. Regardless, it's slow.
it is a small amount, and to me, I usually tell patients like it will get better. You might notice that you have a numb spot, but that's pretty common after a surgery like this, So I wouldn't worry too much. But if it continues to persist, that's where I might consider doing other like nerve stuff like tensioners or anything like that, just to see if we can
Yeah, a
create
little bit
that
of
change.
input. Yeah.
Yeah, but other than that, it's nothing too crazy, but just something we run into pretty often. Now, what do you do with persistent swelling? What's your go-to when you encounter
Yeah.
stubborn swelling? Because sometimes that thing just does not leave for months.
Yeah, right. So I investigate first. So my typical line of questioning is, okay, Do you find the swelling change specifically when you wake up? Is your swelling any different than after a couple hours, right? So if they say, yeah, I wake up, it's fine, but then once I stand and walk, it's it's still there. Okay. Or it begins to increase and okay, so if it begins to increase once you get up, are you able to get it back down throughout the day? If the answer is yes, okay, well we have to manage that in some degree. Okay, what are you doing anything specifically that's causing the swelling to come back? If it's just regular activity and walking, it's a little bit difficult, but something is the swelling's there for a reason. There's some kind of response. We're getting some kind of irritation that's causing the swelling to be there. Maybe early on, if it's a couple weeks and it's just kind of sticking around, you might deal with it for a little bit, right? We had a big surgery, big trauma to the joint, so it might just kind of be there. But if we're like 4, 5, 6 weeks down the line, we're still getting like a pretty quick swelling response to any kind of activity. It's kind of, as long as it's going back down by the next morning, I usually just stick with it and keep working the joint as long as it's not limiting activity. But if it's something where the person's able to reduce it on their own with, ice, elevation, whatever it may be, then I just encourage them to maybe complete that, reduce the swelling on their own a little bit more often. Maybe it's like, all right, you do your home exercises, you're walking, you do that like 4 or 5 times a day. I want, as best as the person's able to, I want them to follow it with whatever they do to reduce the swelling. So that's that kind of balance, right? Especially if we're in that like subacute or 6 to 12 weeks after or more after the surgery. I don't know if the swelling's really supposed to be there to the degree where it's limiting stuff, right? So I'm always asking, when are you getting it? Does it come back down by the next day? And do you find it swells enough where it like limits you? And then depending on the answers to those questions, I address it differently and then just kind of come up with a plan for the patient. But if it's like that low grade type swelling that's kind of there, but it's not stopping them and they don't really notice a change and they're doing everything and function is fine. To me, that's just, okay, that's part of it. It might be there for a little bit. Maybe it's just there chronically until it settles down. But how about you? Anything you specific for the swelling, asking these certain questions? What are you looking for?
I think for the swelling, the biggest thing is like I will definitely keep it moving. I will definitely have them elevate it, do their ankle pumps, stuff like that. And then I will also give them a compression sleeve as well too, to make sure that the swelling gets pushed out as best as we can. I also tell them like this could be a way that your knee is telling you that's had too much. That it's right. Hey, we need to back off of it. But if it's something that stays, then that could just be normal. And I look at the swelling. If it's something that is like still actually just swelling and not edema, then that kind of tells me that A, this can still move, or B, maybe we're doing too much. But if it's edema, then that could just be how their knee is responding. It's just problematic swelling,
Yeah. Yeah, go ahead.
Go ahead.
Yeah, I like to address it. I like to find ways to not work around it, but also have them be able to move, but also empower them. Like, hey, if you're able to reduce the swelling, try to do it. Like I said, I like that 1 day turnaround time, especially post-op. It shouldn't be sticking around so much, but if it does stick around, then my follow-up after that is like, hey, do you have enough swelling where it stops you from doing the same amount of activity or the same amount of your home program as you're able to do if it wasn't swollen, right? So, yeah, I just asked those regards. I'm certainly not, if it's swollen, I'm not completely backing off and let it settle down, right? I think that we can work with the swelling. So there's certain questions we ask, certain guidelines they can follow to have the best outcome, even and be able to work around the swelling. All right, Kane, anything else you want to add?
No, I think we covered a whole lot today. This is a definitely extensive topic, and I think we have a couple more things that we want to be able to touch base on just to wrap things up for our total joint series. But yeah, I think we got through a whole lot of frequently encountered issues.
Yeah, talked about how we get range back, stubborn knees or hips, strategies we use, baselines that we look to get people back to, the use of functional movements for getting range of motion back, and the common issues, if they come in with a flexion contracture, what do we expect? How we're getting extension back, how we're getting deflection back, and we finished with, is numbness an issue? Do we address these joints mechanically afterwards? Working around swelling and how we address it, right? All right, everyone. That concludes today's episode of the PT Good podcast. Remember to leave us a like, subscribe to us on whatever platform you're listening to us on. Follow us on Twitter at PT Good Podcast. We thank you for listening. We hope you enjoyed, and we will see you on the next episode.
Miss you, love you, bye.